Hi guys, Dr. A back with another After Hours Clinic podcast. Didn't have anything planned, so I'm just doing this off the cuff. I'm just seeing if there's anything interesting in the news worth talking about. So let's do this. I don't know that I've developed the most um, efficient strategy for perusing the news, but let's kind of walk through it. Let me see here. All right, so this is. I just Googled health news. I don't know if that's like a boomer thing I just did, but let's kind of run through it. Okay, measles exposures in Colorado. Okay, people aren't getting vaccinated, getting measles makes sense. Origin of deadly cancer affecting young adults revealed in alarming report. Let's see what this is all about. Okay, disease rising 3% annually among 20 to 49 age group with rectal cancer cases increasing to one-third of all diagnoses. So yeah, I know it's Fox News and you wonder if it's, what's true, what's not. But yeah, it's actually true. When we look at young people, in general, cancer rates are trending down with the exception of colorectal cancer. That is something that is going up in the younger 20 to 30 age range. And we're seeing more cases, and there's, been some high profile cases in the news. I think most recently lost Dawson from Dawson's Creek, unfortunately, colorectal cancer, and he's one of those, young people who didn't have screening. Oops. Unfortunately, with colorectal cancer screening, as most of you probably know, that the recommendation starts at age 45. Fortunately, the reality is recommendations generally do not keep pace with the speed of medical knowledge, right? So we're gaining all this information right now that people are developing colorectal cancer at higher rates at younger ages, yet we still have not moved back the age of screening. So that headline is true. So let's find out what the cause is, though. More than half of colorectal cancer cases can be linked to high-risk behaviors, the research said. Those include lack of nutrition, high alcohol consumption, smoking, lack of exercise, and obesity. Interesting. I was not aware that I'm not sure, wasn't aware of that these impacted disease progression that much. I mean, I wasn't aware that they were attributable to half the cases. Of course, I would have to do a little bit of digging to see where they're getting those numbers. But suffice to say, I mean, it's certainly all of these are kind of lifestyle modifications that we'd make for general health anyway. So I wouldn't say this is necessarily that groundbreaking, but okay, I'll take it. Let's see. Okay, more about measles. Okay, what to know about how GLP-1 medications might fight addiction. Okay, interesting. So yes, this is actually an interesting phenomenon. And it's, I think, something that, I'm not sure if it was initially studied or if it just, was studied because of just the sheer amount of anecdotal data of people with some kind of addiction, whether it's a smoking addiction or a drinking addiction or whatever, noticing that they have less cravings after starting on something like a GLP-1, like Wegovy or Zepbound or the generics. And, this is kind of an interesting phenomenon. I have a lot of patients that have told me, like, oh, yeah, like one of the major benefits I get from this is I notice that, instead of having 5 or 6 drinks, I might have 2 or 3. And obviously that aids in weight loss, but also helps, with their overall health. So, and this has been kind of investigated. I know there was a study published in Nature where they looked at the role of the GLP-1 receptor in the brain and how it downregulates that kind of addiction pathway in the brain. And there are some human data out there that, largely observational data based on patient reports that have shown some modest decrease in drinking behavior in patients on GLP-1s. So let's see what they have to say here, what we know, what they know, because I might not know it yet. Okay, so it looks like they're referencing a study in the British Medical Journal, and in this study they analyzed data from the electronic records of more than 600,000 VA affairs patients with diabetes over 3 years. They compared people who received GLP-1 drugs with those treated with medications that lower blood sugar. Well, GLP-1 is a medication that lowers blood sugar, so I guess I found that line confusing. Sorry. Patients were divided into 7 parallel groups that analyzed the risk of developing addiction to multiple substances, including alcohol, cannabis, cocaine, nicotine, and opioids. Another trial looked at the risk of specific harms among people with existing addictions when they took different types of medication. However you say that guy's name's Ali and his colleagues found that people starting the GLP-1 had lower risk of developing addiction to multiple substances. Compared with other medications, people taking GLP-1 drugs had reduced their risk of addiction for 18% for alcohol, 14% for cannabis, 20% for both cocaine and nicotine, and 25% for opioids. And in patients who already had substance abuse disorders, starting the GLP-1s was linked with 31% lower risk of emergency department deaths and 26% lower risk of hospitalization, 25% lower risk of suicidal thoughts or attempts, and a 39% risk of overdose, lower risk of overdose, and a 50% lower risk of death. Wow. Again, this is obviously observational data, meaning it's not a randomized trial where they're, placing people with addictions on the medication of interest, in this case GLP-1s, and comparing it to a placebo and following them over time. This is actually just looking, I'm not sure if they're looking retrospectively or prospectively, but they're basically looking at a large cohort of patients in the VA, and they're seeing the correlation between being prescribed GLP-1s and the risk of certain addiction-related outcomes. So I'm gonna find this article. I think this one, I'll probably read this one. Let me see if I can save this. Cool. I'll just save this guy here. Okay, worth reading. Holy Grail weight loss. Okay, what comes next? Oh, this is interesting. I've heard about this one. So I believe, so the studies find surprising trend among Ozempic users taking fewer doses than usual. The findings suggest that tapering could help GLP-1 users reduce their medical bills while maintaining their weight loss. Okay. Yeah, so this is a huge question that comes up. I get this all the time. How do I come off this drug? Because I think most people, when they start Wegovy, they're really not intending to be on it their whole life. And the reality is this medication was formulated specifically to be for long-term use. Because previously, weight loss medications, the most effective ones were stimulants, and they were only approved for 3 months at a time by the FDA. Of course, people practice outside the guidelines all the time, but the reality was there wasn't really an effective long-term medication prior to GLP-1s. So the idea was very much for people to be on forever. And obviously that's a great business model. Now, does everyone need to be on the medication forever? No, absolutely not. No, most medications are medications that people do not need to be on forever, right? But, there are a fairly large subset of people that probably do need to be on this for extended periods of time, almost indefinitely, right? Because the reality is, when we're talking about the general population, if we look at the data that was published, in the original STEP trials, where they, assessed the efficacy of semaglutide, they did a crossover trial where they switched people off of semaglutide back onto a placebo, and there was, a substantial weight gain of I think it was 2/3 or 3/4 of the weight came back. And of course, that doesn't account for the change in body composition that a lot of these people experience, because as I've harped on ad nauseum, there was considerable amount of muscle mass loss in patients who lose weight with Wegovy, particularly those who lose it rapidly. So again, when you gain even 2/3, 3/4 that weight back, oftentimes your percentage body fat even goes up, making it more difficult to lose weight the next time around, right? And that's a common refrain that I've heard is like, patients will say, oh, I was really successful the first time, then I tried again and it's not working. And I think that's because metabolically they're at a more challenging place, right? It looks like, let's see, this is published in the Journal of Obesity. So let's see. Let's just go to the article. I'll probably read this one too, because this is definitely germane. So I was just reading the abstract here. Again, we can't glean everything from the abscess, but the abstract rather. But big picture, let's take a look. So retrospective case series in 30 adults who achieved weight plateau while using weekly semaglutide or tirzepatide. Patients transitioned to reduced frequency dosing, usually every other week. Data were collected at 3 time points: pre-treatment, plateau, and maintenance. Primary outcome was change in body weight. Okay, secondary outcomes. Okay, so let's look at this. The average person there had a weight of around 87.9 kilograms. And at their plateau, they hit about 74.1 kilograms. So 13 kilograms lost until they plateaued. And at the plateau, it looks like they switched them over to every other week dosing. On average, they continued to lose a little weight over time. So they did not have weight regain with this strategy. So their conclusions is perhaps this could be a good way of tapering people off so they don't gain weight. It's an interesting concept for sure, and it makes sense intuitively, right? It's a strategy that I've used in the past with patients. And I think patients actually will kind of do it themselves. Honestly, those who are using the compounded variety. I want to read the study. Obviously, it's a case series, so there's no control. It's literally just looking at 30 patients and see what happens. So when there's not a control, it's hard to know if that's a real effect, right? Because, especially in a population that small, if they're all receiving treatment, there could be some bias influencing the outcomes, like perhaps they are receiving, more one-on-one attention with dietitians or staff. I don't know. I haven't read the paper, but it'd be interesting to look at all their protocols. Such a small series. This is how you start, an investigation right into a bigger question. So I'm not imputing the study. I'm glad they looked at it. I think it is something that needs to be explored further. Obviously, 30 patients without a control, we can only draw so much. But I think maybe the headline is perhaps a little, more promising than we can, extract from what's actually there. But I personally will definitely have a look at that article because it's a topic that I think is very germane to what I do and for what a lot of you see me for. Okay. Now let's go to some legacy media, Wall Street Journal. Let's go to the health section. Federal officials facing criticism from lawmakers for recent rejections of rare disease drugs attacked an Amsterdam-based biotech company seeking approval of Huntington's disease treatment and accused of lying. Okay, so what is Huntington's disease? Huntington's disease, for those of you who don't know, is a horrible, horrible neurologic disease. It is genetic. It most commonly is passed down from parents to children, though there are cases that occur sporadically out of nowhere, right? There's so many things that make Huntington's so very diabolical, as the kids would say. One, it sets in usually middle age, and it is a progressive neurologic disease that is incredibly uncomfortable, distressing, and uniformly fatal. Once you have it, it's game over. Uh, the other thing that makes it so horrible is I mentioned it's genetic. It's not only genetic; it is passed down in an autosomal dominant fashion. What that means is if you have a parent that was diagnosed with Huntington's disease, that means you have a 50-50 chance of having Huntington's disease. And the worst part is when you inherit it from a parent, there's this concept called anticipation, where a genetic disease actually turns on sooner in the offspring than it did in the parents. And I've actually had patients whose parents died of Huntington's disease, and it is this really heartbreaking thing where they have to determine at some point, do I want to get genetic testing? Do I want to know? Because if the answer is yes, I have it, I now know that I'm going to die early. Do I want to take that information and plan for the future, or hope for the best and not have it, and kind of get that relief? Or do I want to live my life not knowing because I know knowing would be too devastating for me? So this really heartbreaking, really heartbreaking scenario that people with that family history find themselves in. I've had some patients that come to mind that really, really break my heart. I remember I had one in particular was a gentleman. He saw me for weight loss back in my old practice, and he was one of those who carried massive amount of excess weight. He's the type that I look at and think, they may have it like what's called a monogenetic cause of obesity, meaning a cause of obesity that we can link to one gene. Just because when you see people get that heavy, it becomes more common. But this guy was someone who, struggled with daily living, struggled with walking, struggled with, his work, all that stuff. And, we were able to get him to lose weight really successfully. And he was over the moon. I remember him telling me about how, for his birthday, he and his friends got together and went for a hike because he could never do that before. And, that's one of those, like, you feel like shedding a tear kind of moments, right? And he was just the personification of gratitude. And this whole time, he had never mentioned the fact that Huntington's was in his family. And it was only like at one of our meetings that he talked about how his sister was going to get genetic testing and how he was still weighing on him. And yeah, it was just, I left the position before, he ultimately made his decision. Um, but it's one of those things that obviously sticks in my memory. And right now I'm like crossing my fingers, like knocking on wood that he got that test and was negative. But anyways, sorry, that was a long aside. Bottom line is any drug that could promise to treat Huntington's disease obviously gets our attention. Now, as we know, just because something treats a disease doesn't mean it cures it. And as we've seen with Alzheimer's drugs in the past and a whole variety of other drugs, although something gets approval and is quote unquote statistically superior to a placebo pill, that does not mean that it's highly effective. So let's see where where this is all going. So I'm just going to read for a second. Forgive me. Okay. So yeah, apparently, I guess the story is that the FDA rejected the approval of a proposed Huntington's disease treatment on the basis of not meeting the criteria for for approval, basically. And I think the argument is that this treatment was not compared against a placebo in the published data. And you've heard me talk about medical studies over and over again, and the importance of placebo-controlled trials to get us the most accurate assessment of a drug's effectiveness. However, unfortunately, there are times where that can be challenging to get large trials like that. There are two cases. One, if it's a really rare disease, it's hard to get enough people into the study to have a really high-powered randomized placebo-controlled trial. The other, condition where it can be difficult to do a placebo is if the intervention you're looking at involves like a procedure or a surgery that's really invasive. And that does happen, right, where they have to compare surgical procedures and they will do something called a sham surgery where they, basically make incisions but don't actually do the surgery to compare. That's the placebo. Apparently, this drug has to be injected through a hole in the test subject's skull. And they're arguing that, hey, we can't do a placebo on this. Is too risky. Like doing a sham on this is too much, And also they're kind of arguing the rare disease point. They're arguing that, hey, we have a drug that's showing basically showing very promising results in case studies. And for the people that have this disease, imagine if you have this disease and there's no other option out there, you're probably jumping on this train, right? So their argument is like, hey, have some compassion, approve this. There was some mention in the article of like stock prices going down. So who knows if there's some insider, kind of finance game going on here. I would not be surprised given everything that we've learned about the government from the Epstein files. But I'm certainly not an expert of that. But I am an expert in medicine, so I'm curious learning more about what this drug is. Because to me, I could see their point and why it'd be hard to have like a true placebo-controlled trial. I might be interested if I'm seeing just profound benefit. So that is something that I will be looking into. I won't bore you guys going in, looking at all that, but apparently it's the medication is called Unicure. My wife's a neurologist, so I'm sure she'll find this fascinating too. Interesting. Yeah, that is actually very interesting. Okay, let's see if we got anything more. Okay, are multi-cancer blood tests ready for prime time? I can answer that. No, they're not. So, what is this about? Like a little background. So there are now these kind of newer tests out there called liquid biopsies. And what they do is they're a blood draw. They take a sample of blood and they look for fragments of genetic and epigenetic material that is released from cancer cells. So if you remember from biology class or health class or whatever, what is cancer? Cancer is a syndrome where there is a dysregulation in the cell growth cycle such that cells grow autonomously and without the signal to stop, right? So it's just uncontrolled growth of tumor, right? That eventually can spread. And whenever you have really rapid growth of cells, you get cells that die in the process. Some cells are created while some are dying. Those dying cells will release small amounts of genetic and epigenetic material into the blood. And these tests try to detect that with the idea that we can hopefully detect cancers earlier than they may be seen on an imaging study or even perhaps like a colonoscopy or advanced screening technique. The idea is that while a tumor is really early, you may not see it on an MRI. It may be too small to see. It may get buried in all the rest of the tissue, but perhaps we can, detect it earlier by getting the small fragments of DNA in the blood. On its surface, and I think just the idea of it is brilliant. It's really promising. I think this is something that is going to develop with time. And in fact, there is already an FDA cell-free DNA test for screening for colon cancer. And, that test is relatively effective. It's about 90% sensitive, which means it'll pick up about 90% of colon cancer cases. But, it's not as good as, for example, stool-based tests, which is around 95, or, the gold standard of colonoscopy. But it's there for people that, for example, don't want to get a colonoscopy or know that they're not going to do the whole stool collection thing. There are plenty of people like that. So I think it certainly has its place there. But, what's I think being marketed to the broader public is this idea of multi-cancer screening, right? Imagine a test that screens for 50 different kinds of cancer, all by looking for fragments of DNA in the blood. And that's what the Gallery test by Grail is. It does exactly that. It screens for 50 different types of cancer. But it's not a crazy expensive test. It's $900. It's not cheap, but for a lot of people that have excess money, they are asking about this test. And what I've seen so far in the data is this: the degree to which this test is effective really varies by cancer type. And the truth is the sensitivity, meaning the efficacy of detecting cancer in early stages, tends to be really poor, to the point where, you're probably going to pick up cancers, but they're going to be mostly stage 3, stage 4. And how much is that going to impact the overall morbidity and survival associated with cancer? That's unclear. And I'm not aware of any trials that have, shown a clear mortality benefit in using this as screening. Let's see what the article has to say. Okay, so it looks like there's a randomized control trial underway, and that's what this is about. Apparently, as I mentioned just before I read this article, that to my knowledge there wasn't any clinical trials that had looked at actually using this test to reduce cancer morbidity, mortality. It looks like this is a study. It doesn't give the details of the study and how it's set up, but it looks like they are evaluating GRAIL in a large population in a randomized controlled trial, where they're looking to see if Gallery screening can reduce the development of late stage cancers. It looks like, according to the article, that there was about a 20% reduction in stage 4 cancers, though I believe it mentions up here that it did not reach statistical significance if you look at both stage 3 and stage 4. So it looks like there's a slight decrease in this trial that hasn't been published yet. So, we'll be waiting that data, but it looks like perhaps they were able to reduce the incidence of certain very late stage cancers. But again, it does not seem there's, again, when you're talking about stage 4, yes, it's great that they're getting less stage 4. But, really the question is, how are we getting it in the early stages? And as this article points out, and I mentioned earlier, the sensitivity for early stages cancers is around 30%. So it's not great. So are these tests ready for prime time? Absolutely not. Can they be used in conjunction with broader screenings in patients that are high risk? Absolutely. Yeah, I think that is one thing. When we're talking about tests like the GRAIL test, right? There is this concept called a pretest probability, right? And the idea is that the higher your propensity or your risk of having a condition before the test, the more likely it is that if you get a positive test, it's actually important, right? Whereas if you're very low risk for a condition, some of the tests that come back positive are going to be false positives. So, for people at higher risk, combining with one guideline-based screening at bare minimum, but preferably ahead of the guidelines, evidence-based cancer screening, meaning things like obtaining a colon cancer screening at age 40 instead of 45, MRI of the breast for patients who have dense breast tissue as opposed to ultrasound. A high risk lung cancer screening and non-smokers starting at least age 50, like those kind of add-ons that you could be doing in addition or ahead of the guidelines. Those are some of the examples. If you're combining with all that, and let's say you want to go for broke and just combine that with a full body MRI and the Gallery just to be thorough, yeah, if you have the extra money and you have the risk, there may be some role in this. But I think this article mentioned that the company Hims and Hers is advertising them, and everyone who knows my story knows I have nothing but ire for the telehealth. Basically the private equity backed telehealth companies that are popping up like Hims and the ADHD companies that are now under prosecution for shady practices. Because when you see this, they are selling you things, and they're selling it as everyone needs to know. Everyone's got to get this test. No, please, if anyone ever if there's ever you go to a medical setting and there's just a protocol run, the thing is medicine, there's nuance to it, right? And the way you apply a treatment or a screening program should be individualized. There should not be a one-size-fits-all protocol that everyone gets. I see this all the time with these fly-by-night telehealth companies. Beware. Talk to a professional. Talk to someone who knows what the fuck they're talking about. Because when you call Hims, you're getting a nurse practitioner who basically has zero credentials, zero knowledge. They're just slinging drugs for private equity. That's what they're doing. They're not medical professionals, in my humble opinion, which is not that humble at all, I guess. But yeah, so interesting stuff. My brain is a little fried because I'm 40 minutes into talking to myself. So I hope you found this entertaining. I will continue to peruse the news for you guys so you don't have to, and come back to you with the breakthroughs in medicine that are actually hard hitting and relevant to you. If you like this, please drop a like and subscribe. Please send questions in the comments or critiques even. They don't even have to be about medicine. You can just talk shit about my hair or, glasses, whatever. Beard, I've got the beard of a 18-year-old. That's something I'm very insecure about. But yeah, any attention is good attention. I really enjoy doing this, and I look forward to doing it again in the near future.